Hello, good morning all. Can you hear me? If you can hear me, can you just wave your hand? Let me be sure I can hear me. All right, thank you very much and welcome to today's tele-echo session. My name is Prosper Onyekachukwu and working with me and my colleagues, Dr. Azokan Naji, Mariam, and the rest of the FIS3 connected remotely. Today is another special day for our echo session, and we'll be looking into a very interesting one today. And we have a guest that will be speaking to us from India. That is going to tell us more or, exemplify what echo is all about. We also have another of echo executive that's from the US, but actually will be speaking to us from Ghana, among other things that we're going to be unveiling today. But before that, I'd like to ask that all the facilities on the call, please kindly turn on your video. If you're a facility on the call, we need your video to be turned on. And after the presentation, if you have questions or even before the end of the presentation, you can just send us your questions on the chat box. So I will quickly want to call on the Federal Ministry of Health to give us an opening remark, and standing by to do that is Francis. Francis Ajuk, are you there? Can you unmute yourself and let's hear your opening remark. Francis, please, over to you.
All right, thank you very much, Mr. Prosper. Can you hear me?
Can you please speak up? We can hardly hear you. Hello, Francis, can you speak?
Yes, I'm speaking. Can you hear me?
Yeah, I can hear you now.
All right, thank you very much, Mr. Prosper. So on behalf of the National Coordinator, Dr. Akude Grazu, the head of SI, Dr. Adebobola Bashorun, I want to welcome everyone to today's HIV Spice Echo session. I welcome the representatives of CDC, APIN, FIS3, other implementing partners, and other facilities that are present on this call. Let me especially welcome our guest subject matter experts that will be taking the presentation today in person of Dr. Chand. Today we'll be looking at mental health and behavior change for HIV patients in Nigeria. I want to implore us all to fully participate, ask questions, and make comments when necessary. Once again, I welcome everyone and wish us all a fruitful deliberation. Thank you very much, and over.
Thank you very much, Francis, for that remark, and thanks to Federal Ministry of Health for your ever active and support on the project. Again, I will also want to call on CDC representative in the person of John Essien to give a goodwill message from CDC. John, please, over to you.
Hi, Prosper, good morning. Can you hear me clearly?
Yeah, I can hear you, confirm.
Yeah, good morning, Prosper. Good morning, everyone on the call. Today, it's really exciting day again. Welcome to the echo session today on mental health, behavioral change for HIV patients in Nigeria. And Dr. Chan, welcome too. It's good to have you on this call today. FIS3, really want to take this opportunity to appreciate you guys for, coordinating this week's activities, despite the pending challenges that we encounter at the beginning. Yeah. So today is a very interesting one again. Impairment in mental health, has led to negative health outcome at each stages of our HIV treatment. So starting from a point where people are being diagnosed with HIV all the way to achieving viral suppression, mental disorder can be a barrier. And I trust that Dr. Chan has a lot to share with us today on this mental health session. And we're all looking forward to sitting here, and I'm ready to learn from Mr. Chan today. So on behalf of CDC and the country director, I'd like to welcome everyone, and stay tuned and be attentive. I believe we have a lot to take away from today's session. Over.
Thank you very much, John, for that. So on the call, we have Clark Wigley from University of New Mexico. He is senior executive at the Institute of, at ECHO Institute, University of New Mexico. He's also part of the team that led ECHO activities in Africa and has been providing support to over 200 ECHO partners in Nigeria. And he was actively involved in the just concluded ECO country collaborative meeting we had on Tuesday. And we also have other partners from UNM and ECO India. And today we'll be looking at mental health and behavior change for HIV patients in Nigeria. And standing by to take that is our SME from India. He is Dr. Chand Prabhat, officer in charge at Nimham's Digital Academy Center for Addiction Medicine, and then Department of Psychiatry at the Nimham, Bangalore, India. Dr. Chand, please, it's nice to have you present to us from India. Well, I suppose you're supposed to, you should be sitting with us here in Nigeria, but no problem. We are glad that you're joining virtually. So Dr. Chand, please, you can unmute yourself, share your screen, and let's have you have about 35-minute presentation time. Over to you, Dr. Chand.
Thank you very much, Prosper. Thanks, CDC and Federal Ministry of Health Nigeria and many collaborators to have joined from here. At this point of time, it's around 3 p.m. at India. So it's good morning to you all. But it's actually good afternoon at this point in India, in Bangalore. So as Professor mentioned, I work as an addiction psychiatrist, professor of psychiatry at National Institute of Mental Health and Neurosciences. Before I start the program, I assume you all have the smartphones. So let's have a small, I will probably share a little bit and show you how to do it. Yeah. You can go to Slido. Maybe if you can, I'm not able to share my screen, but then it's fine, I think.
Okay. So, Dr. Chan, are you unable to share your screen?
My phone, actually, if you can allow my phone to share the screen, then I can show them how to get into the system, if you allow me.
No, we can share from here. We can share the screen from here.
Okay, no, I was fine. I can do from, don't share it, so I'll do it from here, no problem. I'll do it. Okay, let me do it. Okay, the link is in the chart. If you can look at the chart, you get the link. Manju, can you share the first question? Okay. So, question, I think you will already started voting it. I'll just maybe, Manju, can you share the screen? Yeah. Okay, fine. So this is done. It's already coming. So the question is, first question you can get, if you want to go to slido.com in Google browser. No need to download anything. Go to browser slido.com. You'll ask for a code word, that is SPICE. In chart also, I think the link is there. So the question is, what is your energy level at 10 a.m. at many parts of Nigeria and other countries? If it crosses 4, we have session. Below 4, you can maybe get the content and finish it faster. Okay, so it's completely anonymous. Nobody know who is responding what. Feel free and vote it. So yeah, that's fantastic. 16 votes. You can see the link in the chart. You can just click that link and get into it. I am again sharing that link in the chat for all of you. So this is the link, or you can go to slido.com and event code is SPICE. That's good. So we have good amount of energy now. So 4.0, that's good. So I think 30 colleagues are on the program. Out of we have 330, or that's 10%, make it 60 at least. Okay. Can you go to next question? You can still, automatically question comes in a system, nothing to do. Next question, please. What is the strangest thing you did in the Zoom meeting? In last 2 years, last 3 years, all COVID. It's anonymous, just click. What is that you did? And let me join also. So what is this? Then we'll come to small quiz and then we'll start the talk. breakfast, workout. Yes, it's anonymous, so don't worry at all. Whatever, it's completely anonymous. Yeah, now you're getting proper response. That's. So many people did breakfast. That must be early morning meeting, so you have to have breakfast in the morning. That's good. So those who could not join, just look at slido.com, put event code SPICE, or you can QR scan that one, you'll get it. That's good. So first one, I don't think the answer is there, but second one, obviously, breakfast, exercise, laundry, and video. It looks like this we following same trend. Just a minute, a couple of seconds, we'll wait, then we'll go to next one, and yeah. Okay. Right, before I go to the next one, Manju, can you change the poll to the QA in the screen itself? Yeah. So in your phone, when you see, you can also see a QA section in a smartphone. The whole slide is already available there. What I'm going to present is available to you in the QA section. You can definitely access it if you miss out in between. And you can also ask questions during time. Go to the poll again, Manju. Yeah. Okay, so we got answer. So 40% did something, they don't want to tell it. That's good. I mean, we all agree. Next question. Okay, tell me. If you want to a desert island, whom you want to take with? A person. Don't tell food or camel or no, tell a person name. Whom do you want to take? So you are going to desert land, whom do you want to take with you? No, so Mahatma Gandhi has gone to, that's nice to see. Somebody's put. Wow. So the bold one is the highest hits, and the others are lowest, Spouse and wife both are same actually, so probably, I mean, when wife, spouse means husband or wife is wife, so. Oh, that's nice. Viola Davis. That's good. Okay. Right. So it looks like everybody wants a spouse. Then, I mean, first is Jesus Christ, then spouse. I think many others are, but I think it looks like the spouse and the Jesus Christ and spouse are the most, either people are very religious or people are attached to family. Next, go to next. Okay, now let's join for the quiz. Yeah. Okay, this is about HIV. Before we go to HIV and mental health, let's have a recap a little bit. You can all join for the quiz, and you can just put a name. That's enough. Again, you only know the score. Nobody will know the score. The 5 questions will finish off faster. That's good. On HIV, very basic questions. Maybe who wins, Prosper will give a prize to them on behalf of India. It's too far to send. So I'm putting onus on Prosper to give a prize to the person who wins the quiz. And I remember in this quiz, there will be a timer running in the top. 30-second to 40-second timer. Please respond before the timer or it gets logged. 5 simple questions are there. You could definitely, and HIV, focus on HIV. Then you'll come to the mental health. Okay, let's totally just a minute, Manju. Let's wait for a minute. Anybody else want to join? Last join. Oh, 66. Okay. Should we start in 70 then? 10 seconds. Oh, my goodness. I thought it was some yeah. Okay, let's start. Otherwise, getting late. Yeah. Start. So first question comes here. It's yeah. Timer. You can see the timer on the screen running on the top. And the seconds, please. Question. I think read it. If you're infected with HIV, you will definitely get AIDS. True or false? You have already 36 boards. 10 seconds left. Faster finger also gets little weightage. Yeah, let's see what people think. Fantastic. So we have having the audience is already complete wise audience. So my job is much lesser. So the answer, please. Correct. So I think fantastic. It's good to see 80 people, actively using the phone and so in the question simple, please answer faster because if there is a tie-up, then the lesser seconds you get the prize. Okay, fantastic. So I think I don't need to explain. Go to the next. So then, sir, yeah, next. Yeah, which cell HIV affects in the body? Which cell HIV affects? Remember, vote in the system because it will be calculated here. You can get the rank here, and if you're join late, you can just QR scan the code or type slido.com. Right. Let's see then, sir. I just didn't hold on. Yeah. Okay. So the answer, please. I think we all agree. CD4 T cells, the white cells are T cells. Yeah. Next one. Last but one. Below what count you call its AIDS, where you need to have start pharmacotherapy or medical treatment? What is the cutoff of CD4 cells to call it AIDS? Yes, with 92 people actively using. That's amazing. So nice of you all. Vote here, vote in systems. Don't chat. I'm not looking at chat. Yeah. Let's see. Oh. That's a little bit funny. So okay. So anybody want to give answer? Don't show the answer. Anybody want to just unmute and go ahead? What do you think? I mean, I think in chat I could see many. Okay, there is 200,000. There is dilemma. I'm not sure. I mean, I'll tell the CDC guideline. CDC guideline actually talks about 200 to collides, but some country has actually different guidelines. Maybe I don't know about Nigeria. Anybody can tell what is the Nigeria guideline follows? When to call AIDS?
Hello, Dr. Chand.
Yeah, still sir.
I hope you're monitoring your time. I think you have about 25 more minutes for your presentation.
Yeah. Yes. I will not do more than 5 minutes. I have done. Yeah. Go ahead. My pen is very small. Okay, next. Okay, last one. Then I think Prosper is ready to present. I'll go ahead and share my slides. Yeah. Okay. Little longer time. More than one answer. Please click more than one answer. It's not going to be answer. Right. So then, Manju, I think we're running short of time. Yeah. Okay, go to the last part. And so the winner, and let's congratulate winner, Lan Teresta, I pronounced it wrong, Dixon, Kujeli, and other colleagues. Thanks a lot. You can find your rank in the phone. Let me go ahead and start presentation. I'll take, as I told, more than probably 5 to 6 minutes to finish it up. Yeah. Okay. Now you can see my slide. I think yes. Can you see my slide? Just raise your hand once. Did you? Slides are visible or? Okay, done. Okay, so greetings to all. I'll quickly cover 5 objectives. Facts about HIV and AIDS I've already spoken or already discussed. I'm not going to touch that part. I'll just tell why HIV virus actually comes with a lot of neurological and psychiatric symptoms. Principal common mental disorders, I'll just touch on those things. Principles of care and take-home message. Now it's a global pandemic, we all know it. Look at Nigeria actually doing pretty well. The prevalence has come down from 2.4% to 1.8%. But as in all the part of the world, I mean, the prevalence is very high among injecting drug users, male sex with male, and India it's truck drivers. Maybe similar in Nigeria also when you're reading data out of Nigeria. Now we all just now discuss this part that CD4 T cell is that HIV loves. HIV attacks the cells and make it completely destroy the immune system. There are different stages of HIV. You must be aware of those things. I'm not going to touch that part. Come directly to the what symptom you expect a person having HIV. Now, it can happen in any stage of infection. So it can happen in early stage, initial or later, and there are some symptoms which are combined with HIV and medical symptoms. It's a bidirectional. Now, having HIV or AIDS leads to depression, demoralization, increased substance use, and cognitive impairment. Similarly, the people who have more impulsivity, more depression, more demoralization, they're more likely to get into behavior and contract HIV. The different factors that plays a role for any infection, biology to psychological to environmental factors. I'll start with the first one, this memory deficit. A long-term HIV infection, people will present with a lot of memory deficits. Scientifically, they call it HAND, HIV-associated neurocognitive disorder. Different criteria are there. You can look at these criteria, but remember, one condition with chronic HIV is a memory impairment, specifically recent memory impairment, not the past memory, recent memory impairment. Now, who are vulnerable? Old age, female gender, low hemoglobin, low education, injecting drug use, increased viral load, and less CD4 counts. They're more vulnerable for getting memory deficits. Coming to psychiatric disorders, there many can happen, but I'll touch on 2-3 more. Depression is fairly common. First 2 years is the time when you see the depressive conditions in HIV. 40% of the people with HIV may report depression. A study from the low and middle income countries. This is more common in the higher women and gay men. High risk of suicides are also common in the HIV and the depression in HIV. Common symptoms which can confuse the physical symptoms are fatigue, pain, anorexia, but low mood with diurnal variations like morning time mood is very low, evening little better is one of the core symptoms of depressive disorder. It may be side effect of antiretroviral medication. Keep in mind, somebody on antiretroviral medications may come with depression, which can be side effect of that. So these are the factors that can actually make precipitate depression. Having HIV test, knowing the result, disclosure of illness, and prospect of taking lifelong medication. Now, management, I will not touch on these things, but there is you have to use the medication if needed, but start low, go slow. Coming to manic episode, it's not very common, but it's common in the people who have lesser CD4 count. And when it becomes late onset, it's known as AIDS mania. Drugs like didanosine and jodovidine, which are antiretroviral drug, can also cause manic symptoms. Psychosis, I mean, I don't know the exact term for this psychosis in local language. In India, it's called chronic mental illness. It's not very common. It's not very common to see a psychosis in people with HIV. Maybe in advanced stage you might see, but not in general in HIV positive. Anxiety is very common, very, very common conditions, much more higher than in the female, specifically panic disorder, generalized anxiety, acute stages are common. These are a few symptoms, pre-floating thoughts about future, fear of rejection, being identified as a homosexual or drug abuser, if it is so, are the concerns for the people with anxiety disorder. Last one is drug addiction. Now, remember that injecting drug use is the leading cause of HIV transmission across world, not only Nigeria, across world, including India. 64% of HIV positive patients usually use the illicit drugs. 1 in 4 living with HIV report alcohol or drug use at some part of the time. Now, what is the consequence? That increased neuronal damage, cognitive impairment, more likely to have comorbid diagnosis, higher rate of tuberculosis, SCV, and sexually transmitted disease. I don't know about Nigeria. At my clinic at India, we see a lot of SCV now of late. Last one, take home message. Affected could result in psychiatric disorder. Knowing that I'm HIV positive can itself cause a lot of trauma and emotional trauma, and it can lead to disease. HIV virus has a special affection towards neurons, so that increase the propensity to develop either memory deficit or depression or anxiety. Then elements of being aware of the complex interaction can be helpful for treating, identifying, and giving appropriate intervention when you see a person with HIV infection and any emotional or behavioral disorder. Thank you. Prosper, I've done. I thought I'd finish in time. Yeah.
Oh, okay. Thank you very much, Chan, for your wonderful presentation. I do hope that we all got the presentation, but in summary, this is just looking at looking at mental health and behavior change for HIV patients in Nigeria. I don't know, we may have questions as regards how has mental health, affected our patients in a various clinic, or how would you be able to manage in case if you identify some patients that are both having mental issues and then they are positive, or those who develop mental health as a result of knowing their status, as a result of pill burden, as a result of any of the challenges that are related to the fact that that they are on drugs and all that. So I want to take questions, contributions, or reactions. Clark, your hand is up. Can we have you?
Thank you, Dr. Chand. I wondered if you might spend a little bit of time talking about how in India you guys integrated the mental health agenda into the HIV clinics and things like that. So how did you build capacity for being able to address mental health and behavioral change with the clinics in India? Because I think that's very relevant to Nigeria.
Right. So thanks, Prosper, and thanks, Claire. So what we have done here, we have a two-type approach. One is generic approach. One is high risk group approach. For example, I was involved in HIV and drug use and how to prevent intravenous drug users, because those are the high risk group. In Nigeria also, in India also, the prevalence of injecting HIV among injecting drug users at this point in India is almost 8 to 9%. Because they spread the infection. So what we do we encourage of buprenorphine, that is called Suboxone treatment, opioid treatment, substitution treatment. Then we encourage them as something known as support system where they can get safe needles, syringes for their vaccine program. So this is related to the high risk group. The common group where HIV. At this point of time, last 10 years, HIV has actually come down substantially. The current prevalence of in India in HIV by 0.02%, not so. But that point of time, 10 years back, we have HIV clinic at my hospital where any people develop mental illness, they will come, and then we used to train health providers about how you can identify and do the basic level of counseling for the HIV people, HIV with emotional difficulty, and identify who needs much further care and refer them. So that used to happen very regularly in this program. But currently, we are most focused on HIV and drug use as they are more high risk. Yeah. There is a question in chat. So injection drug use can increase chance of acquiring HIV infection. Absolutely perfect. The response. What strategy employed to evaluate? Okay, I'll probably respond to that one. So one strategy is how you reduce the injectable drug use behavior and injecting behavior and sharing the needle. The two approaches I found effective across the world. Treatment should be much easier. And in India, we have, many parts of the world, actually, there is needle syringe exchange program where free needles are given to the people who inject, and we have methadone or buprenorphine substitution program. So these two actually decreases their chance of spreading the infection in the community. These two have been found effective across most of the part in the world. And yeah, thank you.
Thank you very much, Dr. Chand, for that. Do we have other questions?
If there's more questions in chat, Dr. Chand.
So do we
Okay.
have questions?
Yeah.
Okay, do we have question on the chat box?
Yes. Dr. David has asked a very important question. Are there possible?
Everybody is muted. If you want to ask, please just raise your hand and I will enable you to talk, please. In case if you are trying to unmute and you are not able to do that. So please raise your hand and I will give you opportunity to ask. And then for facility, I think just to start conversation, do you have some difficult patients that will not come for maybe drug pickup, will not come for clinic days and all of that. And then when you try to talk to them, you find out that they are reacting somehow that you begin to wonder what is wrong with this person. It may be a mental health issue. Have you had that kind of situation whereby a particular patient is giving you challenge in terms of follow-up? Come for drug pickup is a problem. Come for viral load testing is a problem. And then you try to encourage them about letting them know that having HIV is not the end of life. It's a problem. Don't you think some of these things could be related to mental health? Have you had anything like that? Do you want to discuss with us and let Dr. Chan or Clark give you, give you more insight on what could be the reason for that? So I just say this to stir up some conversation. Someone raised his hands up and then you brought it down again. Do we have, I'm still trying to.
Yeah. There's a chat question, I think, Prosper, I can take. I think very important question Dr. David has asked. Dr. David has asked that, are there a possible common drug interaction with antiretroviral drug, antipsychotic? Yes, Dr. David, I think perfect and spot on. There is a drug interactions. I did toss that part because of its group is heterogeneous. Many of the antipsychotic drugs are hepatic enzyme inhibitors. Let's take something like quetiapine, or something like maybe carbamazepine is inducer. Some are inhibitors, some are inducer. So obviously one need to be a little careful with combining antipsychotic drug. The propensity, and second point also happens that the propensity to develop the common extrapyramidal symptoms that many of the psychiatric drug creates is much higher when person is already having HIV status positive. So need to be looked at a little carefully before a combination to be given. I completely agree, sir, that your point is that interaction. Yes, thank you very much.
Thank you very much, Dr. Chand. Let's have Techno Spark 5. Can you unmute yourself and ask your question? Techno Spark 5. I'm just doing this, otherwise you're supposed to give appropriate name to your device. Techno Spark 5, can we have you? Techno Spark 5 Pro, are you there? Can we have you ask your question? Okay, let's move on. Let's have Dr. Naji Azuka. Please, can you unmute yourself and ask your question? Okay, let's move on. I think she's trying to address her audio sound. Let's have CHC Donga. CHC Donga, can you please unmute yourself?
Yeah, good morning, sir.
Good morning.
Hello.
Good morning, I can hear you.
I thank you so much for that wonderful presentation. You know, in my facility too, I have site here, and this man is with us for a long time, but he cannot come for drugs pickup unless we first and give him his drugs.
Sorry, can you speak up a little bit? We are struggling to hear you, CHC Donga.
Can you hear me?
Speak up a little bit.
Hello?
Speak close to the mic.
The network is poor. Hello, can you hear me now?
Yeah, I can hear you now. I can hear you now. Please go on. CHC Donga, I can hear you now. Please, can you go on? All right, let's move to Epin Plateau.
Hello.
Hello, CHC Donga. Okay, let's move on to Epin Plateau PSSH. Epin Plateau PSSH. Can you please ask your question?
Okay, good morning, everyone.
Good morning.
There's this, okay, thank you for the wonderful presentation, sir. There's this client of ours that we've been tracking for sample collection. So his response was that, in fact, this year that he promised himself that he was not going to be in the hospital for any reason. So we should forget about the test or whatever it is. So the second time we tracked him, he also gave the same response. So our question was now like, okay, now that you promised yourself that you'll not be in the hospital for any reason this year, should we discontinue you from the program? And he was like, if that is possible, but if anything comes up, I'll still come back to the hospital. So should we tag this a mental health issue or just a personal decision? Thank you.
Good. Thank you very much. Dr. Chand, do you want to quickly respond to that?
Just can you reframe the question again? I got half of it.
Okay. I think echoing the question, he said there's a client, I suppose, who decided not to be coming for drug pickup, sample collections, and all. And then she did not give reason for that decision. Okay, I think she said you don't want to come to the hospital throughout this year, and there was no reason for that. So she's asking, what can this be attributed to mental health, or what do you think? What can be the reason for that?
I think thank you for very pertinent question, very relevant questions, and it's actually it's always a challenge to motivate people to get into the treatment network, specifically infection like HIV. When you don't treat, it may go worse. And sometimes people develop resistance to come to the network. I think there are 2-3 factors you need to look at. One, obviously, at this point of time, this person is not at all willing to come to treatment. He or she is showing resistance to the treatment because he or she might be thinking there's something called denial, that I don't have any problem at this point of time. Although objectively your tests are positive or symptoms are there, but person in denial. So the people like this, or patients or people like this, are often difficult to manage. Now, what can cause denial? First, obviously, is there a personality problem? Is there a personality disorder? Or is there a concomitant, maybe depression? Is there a concomitant poor, the thought that if I have got HIV positive, what will happen to me next? So maybe one way to approach this type of scenario is to leave the testing and HIV a little away and discuss in general thing what is happening in the life. So you may get a light that what we can do best for this person. Because revolving around testing in HIV will further cause agony, and he or she may not like to come further for cooperate in the treatment. But I think these are challenges that all of us face in the practice. So yeah.
All right, thank you very much. Let's take for that question. Dr. Zukayo, can we have you please ask your question?
Okay. Good morning, everyone. Thank you, Dr. Chan, for that wonderful presentation. My concern is in the area of depression. We know that depression has been closely linked to suicidal attempts and suicides. During your presentation on one of the slides on depression, you mentioned that symptoms like fatigue, pain, anorexia, insomnia, and lack of libido can be early signs of depression, and they can be confused with physical illness. So my question now is, how can we develop high index of suspicion as health workers or even caregivers and relations to be able to pick up these signs early enough to prevent the patient or individual that's affected from progressing to that stage whereby the person may begin to think about suicide or issues like that. So is there anything that we can do or anything that can help us to pick it up early, to be able to address it early?
Thank you. Thank you, Dr. Nanji. Thank you very much. I think the point you actually got is absolutely spot on. Many times, the symptoms of HIV, like you mentioned, lethargic, sleeplessness, tiredness, can overlap with symptom of depression. Maybe HIV itself or medication for HIV. So now, what are the core symptoms that make the red flag, that make us to believe that this is going to depression? This is not, and it can worsen if not been taken care of. Let me put the 3 core symptoms that you always look at. First, is there something called this constant sadness of mood? Scientifically they call pervasive sadness of mood. Sadness of mood, we all feel sad in our life in different part of circumstance. Is this sadness of mood is throughout the day or maximum part of the day, maximum duration of the day, not related to any 1 or 2 event? And is it continued for next 2 weeks? Continued sadness of mood for next 2 weeks. Second point, ideas of hopelessness. I'm not hopeful that things will get better. I'm helpless. I don't know why it happened to me. Who is there to help me out? Who will take care of my children if something eventually happens to me? Helplessness. So, and worthlessness. Worthless means, somebody who is, let's say, a teacher, he starts telling you that I don't think that I can be a good teacher in my life. But in history-wise, he is absolutely fantastic high school teacher, teaching mathematics in high school. But now she start telling, I'm not as good as before. So hopeless, worthless, helpless, sadness. These are the core symptoms. And remember, these symptoms would last minimum 2 weeks. If I ask a person, can you tell me, let's see, this is October now, last 2 months back, how are you? How are you? She will tell, 2 months back, I was so good. I'm so well. I used to go to my work. I used to take care of my child. I don't know what happened in a month. Last 1 month, suddenly I start feeling very low, feeling sad. I feel like crying always. Old thoughts start coming, feeling hopeless, although everything is there in my life. So you can actually point out this is a time where things actually got worse. Before that, he was all right. So you can get a timeline. You can get pervasive sadness of mood, hopelessness, helplessness, worthlessness. You are fairly sure the gentleman needs help and should be helped at any cost. So these are the few symptoms, and then obviously you can take further. Now, coming to the second part of your question, suicide. Now remember, the suicide is an extension of hopelessness. You extend hopeless to end, it ends with suicide. I'm hopeless. Nothing will happen. My life has no meaning. Then decision comes. So you have to identify, as you correctly mentioned, sadness of mood, hopelessness, worthlessness, helplessness are the core symptoms of a depressive disorder where we need to, take some help. Hope I have to help you out, explain properly.
Thank you very much, Dr. Chand. Let's take more questions. Maybe I'm going to take 3 now and have you respond to them. You may just jot the question. So the first one is Maraba Guruku. Maraba Guruku Primary Healthcare. Can you unmute yourself, get close to the mic, and ask your question quickly? Maraba Guruku, you've been enabled to speak. Can you unmute yourself and go on with your question?
Okay. Good morning, everyone. I'm Stella Ebe from Maraba Gruku Primary Healthcare. My question is like this. You have a patient that has been on drugs. Along the line, the person came out also, did a viral load, and the viral load was unsuppressed. And at the end of sitting EAC, the patient disappeared, coming back again. The person started, when you try to recancel the patient started behaving irrationally. The communication was not there, nothing, as if it's developing to psychosis. I want.
Sorry, Maraba Group, we've lost you. Can you please ask your question again, please?
To know, is there anywhere we can refer such patients for rehabilitation? That is number 1. Number 2, yeah. Number 2 is the depression, the hope, and other symptoms you find out in a patient first. The network is bad.
Thank you very much. We got your first question.
The network is bad.
Thank you. Can you now mute yourself? We got your first question. So let's move on. Can we have IHVN reverse program, HOS, IHVN reverse program, HOS. Can you unmute yourself and ask your question?
Yeah, thank you very much. Thank you, Dr. Chan, for a wonderful presentation. I have a case in my facility, a young girl that has had a serial viral load test and continued to be unsuppressed So what we did, we had to invite her to come with the mother, and both of them came. So while trying to find out whether there were any form of adherence issues, we discovered that the girl, in the presence of the mother, told us that everything was going on. And the mother also testified that she was taking her drugs according to schedule. But later, when the girl went away from our presence, when the mother wasn't there, it was just I and the mother and my switch committee members. The mother lamented that this girl is very difficult. So I'm wondering, this attitude of this girl, could it be traced to a form of depression, or a form of this girl using her attitude to blame the mother? Possibly, my mother, you were responsible for this transmission to me in utero. So, and if that is the case, other than ongoing counseling, can there be any medical treatment that will be beneficial to this child? Thank you, and over.
Thank you very much. Dr. Chan, can I take 2 more questions?
Yeah, fine.
Okay, so let's have Austin. Austin, can you please unmute yourself and ask your question? Austin? Okay, Austin is not there. Can we have a HB Rivers program, MPHCA? Please unmute yourself and ask your question. IHV Rivers program, MPHC. Are you there? Austin and IHN Rivers program, if you are both there, please can you unmute yourself and let's hear you. Okay, in the absence of that, there's a question from the chat box asking, can you briefly, asking Jan, if, Dr. Chan, if you can briefly talk about substance abuse in ART clients. Substance abuse in ART client. Please, you may now want to respond to the questions. Thank you.
Okay, I'll start the last one because that is my forte, substance use and HIV. So I think it's very, as you're mentioning that HIV and substance use are very, very closely linked, specifically injecting drug users. And I also mentioned that many parts of the world, HIV prevalence is very high among injecting drug users, including India. It's almost 4 to 5%. And I actually saw the Nigeria also around 4 to 5%. So obviously, in our clinic, when we see addiction cases, we normally make sure HIV, HCV, and HBV, syphilis, we test regularly for all the patients who comes with the substance addiction. We get primarily in my center alcohol, cannabis, that is marijuana, and injecting drug use like opioid, heroin, and different drugs. So that's one point. Now, second point coming to first part is that any patient of drug use you see, please check for injection syringe, high risk sexual behavior, which is also very common, and male sex with male. The 3 common areas where HIV can spread at this point of time across different. Now coming to the management part. Now, once you get this history, second part you will get is many of the people who have drug use has a lot of issue in the temperament, a lot of issue in their personality. They're very impulsive to have a long-term bonding relationship. They got into many legal issues, legal issues. So evaluating the personality or temperament is a very key part of this group of people. Third, another group is able to make the treatment accessible and to some extent in a subsidized or free of cost. I'm telling you, addiction treatment is very important, and there should be a synchrony between HIV treatment facility and addiction treatment facility, maybe one place or nearby place, so that or both the team talk to each other so that you can do better. So in many of the cases you can manage in your practice, but some people may need a pharmacological treatment. For example, if somebody is having heavy alcohol drinking, today morning I saw a patient before I came here who used to drink a heavy alcohol, and during the alcohol drinking post drinking, he will go to the commercial sex worker. In they call escorts. In our Bangalore, they call escorts. It's like a places where you can find commercial sex workers. So he drinks heavily, then goes there. So his risk of getting HIV is far higher. So handling that aspect, that cutting down the drink either pharmacologically plus counseling is very essential. Same applies for the injecting drug use, opioid, appropriate treatment like methadone, buprenorphine for opioids. All this should be available for this group of people. So this is for the substance use. So I think I completely agree that addiction and HIV goes together. Coming to the first question, I think I could hear a little less, but the mother issue. Now there are the people in view of their personality try to blame others for they are not able to take care. Now somebody, as you mentioned, is blaming mother, not caring about me. Those are very difficult. Those are more than disease of psychiatry. Those are personality problem or temperament problem. So, but if you want to screen them for a psychiatric condition, on the common scale, I think somebody in chat also mentioned that MH gap IG something is useful, PHQ-9 is also useful. Use some of the small screening test to rule out depressive condition and able to distinguish from depression versus their own personality, how they look at the other part of the world. That's why these two questions I could Prasper got it and answered. If anything else, you let me know.
All right, thank you very much. I won't take further question. Apin Plateau, you may want to share your question on the chat box and then it will be addressed and shared back. So I want to call on Dr. Yetunde, who is a counselor and a behavior change communicator at University of Port Harcourt Teaching Hospital. She's one of our subject matter experts. I just want you to, in 1 minute or two, please give your perspective on the discussion. Your hand was up before. If you can do that in 1 minute, in 2 minutes at max, we will be glad. Dr. Yetunde, please, over to you. Dr. Yetunde, can you unmute yourself now? I've enabled you.
Okay. Good morning, Prosper, and good morning, Prashant. Thank you very much for that wonderful presentation. It's actually a very timely presentation for us in our service provisions to our HIV clients. And like he rightly said, for us, maybe it's not been a concern, it's not been an area that we've always concentrated on, but the truth is that it's the right direction to start going now, because it's important for us that there are various factors that is responsible for an individual's mental health. And then one of it is the diagnosis of an ill health. And so we realize that of treatment, aware of their mental diagnosis of HIV. And so what I'm trying to say is that some persons have mental health issues, but they've lived in denial all this while. And then they get diagnosed with HIV. That's a trigger to their mental health. Yes, there are persons who never had mental health issues before, even during treatment, but because of treatment, because of taking they start developing other means that as service provider, screening it to be done routinely to ensure that people's mental health status are stable in the course of care. And so what that means is that we need to start building the capacity of service providers to learn how to screen for people's psychological state, and then early detection, which is also very necessary, because early detection will actually help to identify cases and then provide possible interventions. And so for us, it is important to take note of the fact that our clients' mental health issues is a great concern currently, which could also be responsible for why we have some non-adherence issues in our clients, or even people who have unsuppressed viral load, like the experiences a lot of healthcare workers are actually sharing with us on this platform. So for us, it's it's a direction to now go. It's a direction, it's an area we need to actually focus on. And for us to do that effectively, we need to build the capacity of our service provider. And if possible, have screening tools available in the program to assess people's mental health, because the issues of mental health is becoming a global concern. And so we don't need to be left out on that. Thank you.
Thank you very much for that. Then my own addition would be that mental health is affecting people. I watched a clip yesterday of an old man of over 67 or it should be 70 years, just climbed the rail of the bridge, and people were trying to discourage him. Don't jump, don't jump. The next thing, he jumped inside the water. That was in Lagos, and that was all. We should look out for each other, no matter how. Mental health is real. Most people have contemplated one action or the other, either suicide or one silly action, which is how mental health issue begins to crop in. Please, let's look out for each other in the office, among ourselves. Let's find out work pressure in the office and anything could cause mental health. So that would be my own addition to that. So Dr. Chan, thank you very much for a wonderful presentation. It's nice to have you virtually instead of being physically here with us. But we look forward for having you physically one day. Again, I want to call on CDC for a final word. I don't know if John is still on the call. John, are you still there? Or anybody from CDC? Okay, I think John is out. So let's have Federal Minister of, okay, before I call Federal Minister of Health, Clark, do you have a final word for us? Clark, please.
Thank you, Dr. Chan. And I think we'll follow up with an email to everybody because I think there's, you know, NIMHANS has really developed a very strong practice around this and lots of best practices and tools that I think we can share. So thank you, Dr. Chan.
Thank you.
Yeah, Dr. Chan, the final word from you, please.
No, I think, you know, the needs are almost same across the countries. I mean, whatever my knowledge goes, the needs, as you mentioned, the mental health needs are absolutely same across the country. It's often neglected, specifically in low and middle income countries like India, Africa. It's neglected, stigmatized a lot. Stigma plays a huge role in people coming out and discussing about things. But this is the right time with increasing people's knowledge and people's capacity to express and talk to each other. Maybe you need to have more echo, as Dr. Akani mentioned, and in Africa and also in India also, so that the ground level health providers, like today they've all joined so nicely. It's 400. I have never seen 400 people joining in ECHO, and not in my ECHO at least. So thrilling to see, and they can do wonderful work. At least screen them, provide the first level, and I can tell 60 to 70% of people you can manage in first level. Then up to the next couple of few percent. I think it's a good time to collaborate among all of us and making things available so that right knowledge at right place at right time. We all know it can save us. COVID has taught us this lesson, and at least we can utilize it now. Thank you very much, all of you, all the people from Nigeria and other countries joining. It's such a pleasure to see all of you. Thank you, and bye-bye from me.
Thank you. Again, someone just draws my attention. Our health-seeking behavior is very poor in this part of the country. It's generally poor. Then we are not even talking about mental health. So general health-seeking behavior is poor. Please, let us talk to one another. Let us share our concerns. When you share, it is lesson. When you share, you will be advised and you'll be guided accordingly. Thank you very much. So let's have Francis from Federal Ministry of Health give us a closing remark. Francis, are you still there? Francis, can you unmute yourself and give a closing remark? Francis, can you try to unmute yourself? You are a co-host. You can unmute yourself now. Labake, are you the one giving a closing remark? Can you try to unmute yourself now? Hello, Labake, are you there?
Yes, I'm here. I'm here. Can you hear me, Professor?
Closing remark from the Federal Ministry of Health, please.
Yes, can you hear me?
We can hear you.
Okay. I don't know if Francis is still on the call.
Please, you can go ahead. He's not on the call.
Not on the call, okay. All right, good morning, everyone. My name is Momo Labake Kundai once again, a Senior Population Program Officer and also the focal person for Spice Echo in the Federal Ministry of Health. I would like to appreciate Dr. Chan this morning for the impactful and very impactful and insightful presentation on this all important topic. We really appreciate you this morning for giving us a full detailed presentation on this topic, which is very important in our healthcare service deliveries. We really appreciate you. And also, Clark, we really appreciate you for being on the call this morning. And also to all our healthcare workers, thank you for being on the call this morning, and also your contributions and questions. It really showed that you were really listening and you're committed to the healthcare service delivery in Nigeria. Also to Dr. Kaniye today, thank you, Ma, for your contribution this morning on the topic mental health. Really appreciate you for always being there and for your usual contributions. And to all our IPs on the call, the CCFN, IHB, NCIHP, AP, and EQs, thank you for always working behind the scene to see to it that all these facilities are always on the call to be part of the Thursday Echo sessions. And also to 5-3, thank you for your technical support all the time and your coordination. We really appreciate you all. And on behalf of the Federal Ministry of Health, the leadership of NASCAP, Dr. Akudek Bazu, and also the EDSI, Dr. Adebobola Basharu, we appreciate you all once again and also wish you all a wonderful Thursday. See you all next week. Thank you. Bye for now.
Thank you very much. And from all of us here at Spice 3, my very self, Dr. Nnaji and Miriam, want to say thank you very much, and we look forward to having you again next week. Please, the presentations, both the recording and the presentation slide will be shared with you shortly. Do use the Google link to access it and use for your own benefit, and please share widely to all the participants. Thank you very much, and bye for now.